Good evening and welcome to our monthly seminar for the Center of Global Health Equity. My name is Joe Kolars. I'm the director for the center, and I think as many of you probably know, we're in our early days for actually getting our center up and going. In September, we started monthly seminars to let people know what our activities are, and more importantly, for us to start to build community. Where our center, I think, will distinguish itself is how we collaborate across the university, but also how we collaborate with our partners, particularly in low-income countries. One of the strategies we've taken as a center is to try and have challenge groups, and these are mini communities of practice, if you will, that try and gather faculty and interested stakeholders in some of the big themes for our Center for Global Health Equity. Last month, we had one of our challenge groups talking about data science for global health. And tonight's discussion will be about empowering women and communities. And again, this is a collection of faculty who are coming together from across the schools to try and think how can we come together to really have impact in women and communities in low-income settings. Each of our challenge groups have a couple of faculty facilitators to, again, pull people in, interested groups from around our university. And I'm going to start off by introducing our two facilitators for this challenge group. Dr. Laura Rozek is faculty in our School of Public Health, and Dr. Cheryl Moyer is faculty in our School of Medicine. So they've been leading the discussions, and I'm going to turn the agenda over to them. They'll introduce our panel, and we're looking forward to a great session. And again, we're in the process of building community. So please look at our website, and you'll find ways that you can connect as we build momentum. So Cheryl, Laura, thank you, and I'll turn it over to you.
Great. Thank you, Joe. And thanks to all of you who are making time for this. I know it's been a long day. Many of you may have been on Zoom all day. So thank you for being here with us. So I'm Cheryl Moyer. I'm faculty in Learning Health Sciences and OBGYN. And my colleague Laura will introduce herself in just a moment. I'm going to take a minute to go through the agenda, but I did want to start out by saying, you know, a lot of people have said, so what is this challenge group? What is this and why are we here? I wish that this were more like an open forum town hall where we could all show up and just go around the table and everyone talk about what they're doing. That's where we are. We have picked a few people who we knew did work that related to empowering women in communities as a way to kickstart conversation with all of you. But please don't see this as that there's some established club that you're not in or that you haven't been invited to, because that is the farthest thing from what we intend this to be. So think of this as a big town hall, a big open forum with a gigantic table where we could all share ideas. So over the next little while, Laura is going to talk to you a little bit about what this challenge group is and what are some opportunities for you to get engaged or stay engaged, and is going to pose some of the questions for discussion. And then we're going to have some comments from Jody Laurie at the School of Nursing, and Elizabeth King from the School of Public Health, and Bridgette Carr from the law school, all of whom do different work that somehow intersects with this idea of empowering women in communities. And then we're going to circle back and have some open discussion. So there is a Q&A, which you ought to be able to submit some questions. And if you could do that with your name and affiliation, that would be great. We will probably go through all of the presenters one after the other and then open it up for some questions. So keep in mind, you don't have to ask the question exactly. You can percolate over it for a bit. Laura, I think you are up next.
Yeah, so hi, I'm Laura Rozek. I'm on faculty in the School of Public Health, and I also direct the Center for Southeast Asian Studies in the International Institute. And like Cheryl, we're really excited to be here today. We see this as really launching and kicking off and bringing people into our little challenge group, which we hope to be a big challenge group. Up front, I know you usually save acknowledgements until the end, but we wanted to upfront thank the challenge group support staff who are putting together the webinar today. You've probably received emails from some of them, and we just wanted to make sure that they're familiar faces to you as well. So Tanya Petrowski, Christina Rice, Christabel Seifa, who just joined mGlobe, and Melissa Lee are all people that you've heard from, you will hear from, and we wanted to thank them for their assistance, ongoing assistance with the challenge group and putting together the webinar. As we mentioned, this is starting out. Cheryl and I were asked to facilitate this, and we've been reaching out to different faculty. So far, we've had interest in about 26 faculty from 10 schools across campus. But we really feel like we're ready right now to really start engaging in a much more formal way. And we're excited to have this opportunity to invite everybody here and people who are listening to the recorded version of this to really get in touch with us. In December, we will have a research jam. We announced this a few months ago. It's December 9th from 2 to 5 p.m. It's open. There is a cap, but we still have room for at least 10 people. And the research jam is wonderful. They're offered by Mishar. Maybe some of you have been involved in these in the past, where they are designed to assist groups of faculty from diverse ranges of disciplines to build collaborations, create research agendas, and develop a strategic action plan, which we feel would be really important for us in this challenge group. We see this as a visioning jam, helping us identify our audience, our value propositions, and our key activities. In January, we will also be launching monthly seminar working group types meetings, which again, Cheryl and I see less as seminars where you sit and listen and more of bringing people together around our virtual table until we can see each other in person. And at this time, we'll also have a Slack site for collaboration, for sharing papers, and for sharing ideas. And we're really excited about all of these things and encourage everybody to participate as much or as little as you are able. We know with COVID and challenges to most people, especially women in communities, it's difficult to be engaged as much as we want. So never feel like just popping in or out is unwelcome. We hope that you can come as little or as much as you can, and we're looking forward to seeing you. And with that, I think Cheryl is going to introduce our first speaker. Each has been asked to briefly describe their work, describe how they think about the concept of empowerment, and tell us whether they self-define around this or not. We haven't had a conversation about this, so we will be watching these de novo as you are. So Cheryl.
Great. Well, we are going to start with Jody Laurie, who is a colleague and friend from the School of Nursing, who's been doing phenomenal work in many places throughout the globe, most recently in Liberia and in Ghana and in Zambia. So Jody's work that we have done together looks at not only maternity waiting homes, which are places where pregnant women can go right before they're due so that they don't have to make a long trek in the middle of the night to get to a healthcare facility, and group-based antenatal care, allowing women to come together in groups so that their antenatal care is also a bit of a group support mechanism. So Jody, I think you ought to be able to share your screen.
I will, thank you.
And welcome.
Thanks, Cheryl. And Laura. Go. It's always finding the cursor, that's the challenge. Okay, hopefully you can see my screen. And I'm going to start by talking about some of the work that I do, empowering women and communities through innovative models of care. And as Cheryl said, I've done a lot of work in Sub-Saharan Africa, mostly West Africa, mostly Liberia and Ghana, but I have also conducted studies in Zambia and Ethiopia. But tonight I'm going to talk specifically about my studies on maternity waiting homes and group antenatal care, as Cheryl mentioned. So I think to start out, I'd like to say one of the things they asked about, and you saw in what we were supposed to talk about, is do we feel like we study empowerment? So I don't necessarily measure empowerment per se. Rather, I would say that I use empowerment in my approaches or methodologies to working with women and communities. So I think one way to think about empowering is partnering with communities to explore the issues, to set priorities, to develop a plan, to kind of work together to execute that plan, and then to evaluate the results together. So somewhat like community-based participatory research. And I think what that lets you do and how that empowers communities is bringing the voices that are closest to the problems to the table. So especially for marginalized and vulnerable communities, this is an opportunity for them to have their voice heard and for them to be able to say what problems are they most interested in tackling at the community level. So globally, in communities where women's groups have been facilitated, they've become a locus of power in identifying problems, in mobilizing resources, and in acting to solve them directly. So what I've really found is that you don't have to come up with any sort of answer. You just have to listen to the communities, and then you can facilitate the things that they know that they need for change to make their health better, to make their lives better. And I think by mobilizing communities this way, we empower them. And I think it provides a positive way for them to interact with the healthcare system, which they don't always get. So I'm going to try to describe a little bit how I've approached this in the research that I've done and see if it resonates with anybody. So as I said, I mainly work in West Africa. I mainly do intervention research. And one area that I do intervention research in is maternity waiting homes as a bridge to tackle the problem of distance for women that live far from a health facility. So I've done this work in Liberia, and we had very positive results. That was over a decade ago. And then because of that work, we were funded to do a similar project in Zambia, in rural Zambia. So how does empowerment fit in this? So the way that it started was that I was actually doing an entirely different project in rural Liberia, and communities would come up, community members would come up to us and they would say, we need to have a safe space to give birth. This was right after the Civil War. And so there was a lot of destruction. There was not a lot of infrastructure left. And a lot of buildings had been burned down in places, and people weren't really used to going into the health facility yet. So they said, prior to the war, we had these birthing huts that we had in the village where women could go to give birth safely in a clean space. And now that we don't have those anymore, the women are going out into the forest to deliver. And we would really like that. So we talked about it with the communities, we talked about it with the healthcare providers, and we decided that we would try this model that had been tested in South America, in Latin America, mainly in Nicaragua, about maternity waiting homes. But rather than just put them into random villages, we would place them near a rural primary healthcare facility. And the women could come there for a week or a few days or a month before they deliver, so that when they go into delivery, when they go into labor, they don't have to walk 10 or 15 kilometers across bridges like you see in this picture, down roads like you see in this picture, to get to the health facility to deliver, because that was really a barrier for them to get to care. And so we talked with them. We talked with the traditional birth attendants, who were very, very much part of this decision-making process, because they really were the ones that held power in the communities. And they told us what they wanted. They wanted a place with a screened porch so that they could sit outside in the evenings. They could have meetings there when they weren't using it as a maternity waiting home. And they wanted places where two people could sleep so that the traditional birth attendant could actually come with them to the clinic. And so that's one of the ways that I feel like we've empowered communities. And they're very well utilized. We had 5 maternity waiting homes that we built in the first research that we did in 2010, and we went back to do an evaluation on sustainability and scalability, and in 2019 there were 115 of these throughout the country. The other place that I've done a lot of work is in with group antenatal care, as Cheryl mentioned. And right now we're conducting a cluster randomized controlled trial on group antenatal care where we group women together by gestational age. And this came about just from being around clinics, being around healthcare facilities, being around pregnant women, and knowing that they were going for care, yet they were going back to their communities. And when they had a problem, they didn't necessarily even recognize that they had a problem. So they were going for their care, but they weren't getting the health messages when they were at the care. So we talked with them. We did a pilot study, a small study in Kumasi to kind of get our materials, to get what we were going to use for these group antenatal care sessions together, to figure out how it was that we could provide health messages in usable formats for women to be able to use that information and improve their health care. And what it really did was it increased a dialogue between the health system and with the communities they serve. So you can see in some of these pictures, women are taught how to do their blood pressure with each other with an automatic blood pressure cuff. So they understand what it means when they have their blood pressure checked, and they understand what high blood pressure means. And then when they get the educational part of their care, they sit around in a group with other women of the same gestational age, and they share ideas. They share things that have worked for them. They share things that work in their communities. They share challenges that they have, and they can all help each other. And they're very, very supportive of one another. And there is one little caveat here. These pictures were pre-COVID. We are still doing this study, but we are adhering to the social distancing and mask wearing in Ghana. That's part of their effort to minimize transmission of COVID. So what this did was really provide a new form of communication for women to be able to negotiate how they're included in the healthcare system, and then to demand adequate quality healthcare for themselves. And I think, again, that's one way that this translates into empowerment. And then finally, my last slide, and to talk about measuring empowerment. And I think this is really a challenge, and probably why I have not actually directly ever used an empowerment scale to measure anything. But I think it really needs to be situated contextually. And then the question I always have is, empowerment a process or is it an outcome? And I don't know that I actually have the answer to that. I think it's probably both. But what do you measure? Do you measure self-efficacy? Do you measure agency? Is it social inclusion? I mean, what are those things that we measure to say that we've empowered communities or we've empowered women? So I think sort of in conclusion of all this, there is a lot of research around this area, but I think we really lack research in areas of community participation, of social accountability, and specifically about addressing gender inequities. So I think we can transform many of the social and behavioral determinants of health through empowerment. I think we just need to be really thoughtful about how we look at it, how we measure it, and how we actually even just use the term. So that is my last slide.
Beautiful. Thank you so much.
Yes.
Well done. So as we said, we are going to hold questions or go through questions at the end. And I think, Laura, were you going to introduce our next speaker?
Yeah, we're so excited to have Elizabeth King speak, who is a friend and one of my colleagues in the School of Public Health. She's an associate professor of health behavior and health education. Elizabeth has a broad range of work in women's health and gender equitable access to prevention and healthcare services, particularly engagement in HIV care and treatment. One thing I've always loved about working and talking with Elizabeth is that she's kind of a true global scholar, though most of her work has been in Russia and Eastern Europe. She's had studies in Africa and other areas around the world and has a great kind of broad basis from which to talk about the topic today. So thank you, Elizabeth, for joining us.
Yeah, thank you so much for inviting me, Laura and Cheryl. And as Laura mentioned, most of my work is concentrated in Russia. It's probably where I've been working the longest, kind of feeds back to my pre-public health life as well. And so I'm going to talk specifically about the work that I'm engaged in around women's access to HIV care and treatment services in the Russian Federation. And just a little bit of brief background. Just have one slide, but since just to kind of introduce of why we would think about these topics, particularly in Russia, is it's one place where the HIV epidemic continues to grow in the world. There are officially over 1 million people living with HIV in the country. However, less than half of people living with HIV are on antiretroviral treatment in the country. People who inject drugs have been disproportionately affected by the epidemic historically in Russia and continuing today, though we're seeing an increase in the number of new HIV cases attributable to heterosexual transmission among women specifically. However, across the board, through women's specific needs have been less studied in Russia. And I also want to mention that, if you look at a map, you see that Russia is a very large country. It expands across 11 time zones. There are vast regional disparities among the country, and particularly with the HIV epidemic, we see that there's about 20%, an increase in 20% of new cases in Moscow, but in some Far East regions, there's 150% increase annually among HIV cases in Russia. So I'm going to talk, and I think that these feed into the themes that that Laura and Cheryl have asked us to talk about with how we're engaged in women's empowerment. So I probably have done it maybe a little bit more implicitly rather than explicitly, but happy to talk about it during the Q&A as well. But I'm going to talk about some work that I've been involved in around specifically looking at women who inject drugs. And this is work that I'm currently doing with colleagues in the Department of Psychology at St. Petersburg State University. And we're partnering with a community-based organization, Humanitarian Action, which I've worked with. I think I met them in maybe 2007, 2008. I spent a year doing my dissertation fieldwork. Their harm reduction van services were my field site for dissertation research around access to HIV for services for female sex workers. And so more recently, we did a study that found that 63% HIV prevalence among community-based sample of women who inject drugs in the city. And this is what we often refer to in public health as double risk. So both from unsafe injection drug risk and unsafe sex work. Unsafe sex, but particularly within sex work. But one of the major gaps is the lack of research on the gender-related factors that influence HIV risk behaviors and access to HIV services, specifically for women who inject drugs. And so our research is really setting out to look at there's a body of research around women's health, and particularly among women who inject drugs. But what are the similarities in those trends in other places around the world and in Russia? But we're also trying to take into account the unique social, cultural, political, and economic context where we're doing the work in St. Petersburg. And so really, we've been working over the last few years, funded by the Office of Global Public Health and the Mishar grant, was to look at identifying and exploring what we call the gender-based constraints and opportunities influencing access to HIV-related and also drug treatment services in the city. We did a qualitative exploratory study design where we recruited through outreach services and through personal referral. Colleagues and I conducted a series of interviews with service providers from healthcare sector, social service sector, NGO, and also used purposive sampling to conduct interviews with women who are currently involved in injection drug use, purposively sampling for involvement in sex work, HIV status, marital status, and number of children. And then we were analyzing the data, or almost finished analyzing the data, using thematic analysis and a team-based approach to coding, which has been really thinking of the strengths of our research team being multidisciplinary and also international. The findings from our study really kind of focus around the issues of fear and stigma, lack of financial security, and really thinking of a need for face-to-face interactions. We're trying to think about ideas for intervention, mobile intervention, which is kind of in person, and that they focus on people thinking about motivation, personal motivation for accessing HIV treatment or drug rehabilitation services. But this motivation is very gendered, and it's tied with issues of fear, stigma associated with HIV, stigma associated with drug use, stigma around being a woman who injects drugs, stigma around being a mother, stigma around not being a mother, denialism, and particularly among male partners, denialism of the HIV virus, and around denying the importance of HIV treatment, partner dynamics, and then gender norms in society. And then kind of thinking about this is, one quote that really has stood out from our research is that this idea, and this is really illustrative of what many of the women that we talked to said, is that, I don't think anyone can help me. I don't believe in rehab centers. Honestly, I don't believe in these fairy tales that someone can do anything. And so we're trying to think about, what could we do given the current constraints on that structural constraints of doing this kind of work in Russia, but doing this work in general and particularly in Russia. But we have been identifying opportunities for intervention and ideas for programming. Last winter, we conducted a roundtable with representatives from the community-based organizations and government service providers in St. Petersburg and thought about how they could integrate gender empowering approaches into their work, what they're already doing, what they could do more of. And our plan is to pilot an acceptability and feasibility of a gender-related empowerment intervention with a small group of women who inject drugs in the city. And then, if that shows good results, we are hoping to be able to then plan for an intervention to test effectiveness and assess implementation possibilities. And so we're planning to resubmit our 34 application to NIDA in the next cycle or so. And then the other area, particularly in Russia, that I want to talk about is postpartum engagement in HIV care and treatment. And this idea really came from having worked on the HIV epidemic for many years in Russia and repeatedly hearing the stories of the only time women who are engaged or have experience on antiretrovirals was during pregnancy, and or that's oftentimes a time when they're diagnosed with HIV as well. And I met an organization, it's a national network of various community-based organizations across Russia that is led mostly by activists and particularly among women who have been affected by the HIV epidemic in the country. And so we thought about, their intersecting ideas, needs, and interests, and my research interests and expertise as well. And we really thought about how can we move the discussion forward about focusing on women's rights to access HIV treatment. And so thinking about these rights-based approach and particularly women's rights. And so we've developed and we've been working for the past few years what I would call a research activist partnership. So we started with a little after I met them when I was doing field work in St. Petersburg. We then applied for some pilot funding from Earwig and then had funding from a few international. I was based in the Netherlands, then received funding for scholarship activism from Earwig, and we're currently conducting an NICHD funded study that I'm going to talk about our program of research here and how it relates to women's empowerment. So we focused on what are the needs of HIV positive mothers. We asked the questions of why do women stop treatment after PMTCT, what helps women stay in care, and what can we do? What are intervention ideas? What packages of services could we offer? What could kind of advocacy issues could we get involved with? And another big component of this research program and this research partnership has an emphasis on training team members and particularly community-based activists in research skills, recruitment, research ethics, applying for IRB, conduct ethics of doing research, qualitative interviewing skills, and survey implementation. So we started with our small pilot grant for MIRIG in 2 cities in Russia, St. Petersburg, mainly because that's where I've lived the longest in Russia during my time there, where the headquarters for the main office of Yeva is. And then we also picked a small town in the Sverdlovskaya Oblast, which is the region around Yekaterinburg, which is the city that's just east of the Ural Mountains, or right, Ural Mountains. And so in that study, we conducted interviews. We used community-based activists for recruitment and for conducting of the interviews. And through this partnership, we conducted 20 interviews with service providers and 50 interviews with women living with HIV to identify and explore factors influencing postpartum engagement in care. And then based on those findings, we came together and worked across 5 different sites to implement a quantitative survey in the Leningrad region, Novosibirsk, Orenburg, Samara, Khanty-Mansiysk, to assess which factors are associated with adherence to antiretrovirals in postpartum period. And then we built on this through a scholarship activism grant to think about how to engage local activists who haven't been involved in research and in building capacity around research skills, and then also with an idea of how we could use this project to also improve access services for mothers living with HIV. And the NGOs picked particularly looking at access to infant formula during the postpartum period. And we conducted that project in St. Petersburg, Ulyanovsk, Orenburg, Yekaterinburg, and Tyumen. And so I won't, kind of go over the key findings, but the other thing that's really great about working with community-based organization is we have a variety of ways to disseminate our research. So some of that is through what probably we're most used to seeing in academia, really interesting. He is working on peer-reviewed publications, but we've also the large social media campaign, mostly fueled by them, blogs, and some of our colleagues presented the study results at the International AIDS Conference in Amsterdam as well. And so also thinking about building, kind of this, I guess, everyone's involvement in disseminating in ways and opportunities that they would like to be involved in. So we found, that stigma around HIV is high. It remains high, whether that's in an urban setting or a more rural setting. Of course, it's nuanced, and some of the articles go into these nuances of this. The side effects of antiretrovirals and the antiretrovirals that are available in Russia, especially given stockouts, shortages, etc. Lack of information, financial insecurity, food insecurity, need for psychological counseling, focus on how important having some kind of support system is, issues around partner disclosure, including issues around intimate partner violence, and a lack of a comprehensive approach, and that there is still a pretty widespread and strong AIDS dissident movement in Russia, or AIDS denialism movement. Counseling is very limited, especially in non-HIV care settings, and this includes upon diagnosis, if one is diagnosed outside of an AIDS center. And we found through this research that women who are diagnosed during pregnancy are in needs of different kinds of support, both personal and professional support. And I'm thinking of women who are diagnosed during pregnancy compared to women who already knew of their HIV status before becoming pregnant. So that led us to what we're working on now. And this is the NIH funded study that's we're really looking at what is this opportunity for women's healthcare providers, and what could their role be in helping and facilitating women's engagement, both in PMTCT, but in longer term engagement in care as well. And so the healthcare system in Russia, part of that is there's government health clinics, women's consultation centers, the photo of one of them there. But so HIV diagnosis, because HIV testing is routinely done during pregnancy in Russia, like many places in the world, this is often provided by antenatal care providers, and sometimes that they're the first ones to inform women of their HIV status. Though the healthcare system is still it's pretty siloed in Russia, and so we're focusing specifically on HIV AIDS centers, specialized HIV care centers, infectious disease hospitals, and these women's consultation centers. And the questions that we're asking is, what is the potential role of antenatal care providers in helping women engage in HIV care and treatment postpartum? And what would, if there is a role and there's a desire to have a bigger role, then what would need to be done to prepare them to counsel and refer for women to other resources? So this project is based in 7 sites across Russia. We originally picked, Russia has 8 federal districts. We picked 7 of them. We excluded the area where Chechnya is because it's a US funded study, and it's there's a lot of other reasons, but we originally picked sites across, we picked 1 site in each of the 7 federal districts in Russia, though we ended up let's say that it didn't work out very well in Rostov-na-Donu after we arrived and did a few interviews. And so luckily, NIH was quite flexible in this, is that we had this really amazing opportunity, made some connections with some people in Kemerovo, and so swapped a site. So if you see, we have 2 sites that are quite nearby. And so we traveled, we swapped it out and went to Kemerovo instead, which has was one place where the HIV new cases continue to increase, and particularly among women. So it actually worked out for the better. We've done work in all of the sites, except I had plans to go in June to Khabarovsk, and based on where you see where that's located, those plans were pretty much diminished in about January. So, but nonetheless, our first phase of this was that Natasha and I, the study coordinator at Yava, we have traveled to the other sites, made several trips around Russia. I put a picture of, spent a lot of hours on Russian trains, but also traveled by planes, buses, and there's that movie, that Planes, Trains, and Automobiles, but Russian trains, luckily I have a strong affinity for Russian trains. So we've conducted interviews with gynecologists and antenatal care providers, nurses, HIV specialists, infectious disease doctors, epidemiologists, pediatric HIV care providers in these various cities. This is kind of a map before we started our trip, and started one of our trips, and then that's in Leningradskaya region outside of St. Petersburg, in front of one of the infectious disease clinics there. And then phase 2 is to conduct interviews with women who were diagnosed with HIV during their most recent pregnancy and who have given birth in the past 2 years. And so we want to focus particularly on women who were diagnosed during HIV in these same 7 sites. And the idea is, it's building on this community-based participatory research, is that local network members of the Association Yava will be recruiting and interviewing women diagnosed with HIV during most recent pregnancy. We have some more specific inclusion criteria for purposive sampling that I won't go into right now. We all convened in St. Petersburg the first week of March for the training, and each person did 1 interview, and then the research for human subjects research restrictions around COVID hit. So we're taking what we'll call our COVID pause, which has allowed us to do a more in-depth data analysis of the first round of data. But we actually just got approved today by to start research again with the, as Jody mentioned, with the restrictions, social distancing restrictions, mask wearing, et cetera, in place. And so we'll see if we're going to restart or if we will pivot. We decided not to pivot to an online interviews for lots of various reasons, but we will see what's in store for us now. So that's kind of where we're at there, but the goals are really to explore factors of engagement in postpartum care, also to build partnerships in the region. So some places Yava has worked before, some places they haven't. I've been to some places before, but I've also haven't been to some other places. And so to really build on where we could have feasible intervention sites, and also to look for best practices across Russia. So see what's already being done, either for formally or informally in some of these settings, and for looking for areas for potential intervention. And so, but especially for trying to think about where we could intervene on if we see women's consultation centers and these infectious disease hospitals. And that's the HIV infectious disease hospital for pregnant women and children in Yekaterinburg. So I'll end there and we'll.
Thanks, Elizabeth. That was great. Just a reminder, if you have questions throughout any of these talks, you feel free to enter them in the Q&A throughout. But Elizabeth, that was a really great overview of your work. And our final speaker, we're going over to the other side of campus to Bridgette Carr, who is the Associate Dean for Strategic Initiatives and a clinical professor of law over at the law school. She was also the founding director of the University of Michigan Law School's Human Trafficking Clinic, the first clinical law program that was solely devoted to addressing this issue comprehensively. And her entire career has been working to advocate for the rights of human trafficking victims and advancing domestic and international anti-trafficking policies. And we're really excited to have her come here today and talk a little bit about her work and how this might fit into MGlobe and the way we think about empowering women and communities around the world. So Bridgette, thank you so much for joining us today.
Thank you so much for having me. I thought I would start just by talking a little bit about the work of the Human Trafficking Clinic and what is human trafficking, and then some of my thoughts around the concept of empowerment. I'm gonna share my screen. My second grader helped me get my Zoom background correct, but he's eating, so I'm on my own for IT support right now. So hopefully you can see this. So lots of folks wonder what we do in the Human Trafficking Clinic, especially folks in the healthcare side of the world, because we're not a clinic in the way that healthcare folks think about. A clinic in the legal field means it's a place where people can come and get free legal services, and students get trained on how to be a lawyer. It's a lot like residency in a medical, in med school. And so here at Michigan in the Human Trafficking Clinic, we represent victims of human trafficking regardless of type of victimization, gender, age, or nationality. And I want to talk a little bit about the words in that sentence. And the reason I want to talk about that is lots of folks are wondering why we're not using a more empowering word like survivors. Well, there's a really strategic reason that we use the word victims. And that reason is that right now, most of my clients get arrested. And so when we use the word victim, we're using that because it's in the law. There is a statutorily defined term for victims of human trafficking, and we are trying to signal to folks that these are not people who should be arrested. And so we have a legal hook to do that. We use that word as a hammer kind of against criminalization. And so I just wanted to be clear about that choice of that term and why we use that. The other reason we say regardless of type of victimization, gender, age, or nationality is that lots of folks in the human trafficking space will talk about human trafficking, but we'll really only be talking about sex trafficking, or they'll only be talking about serving US citizens. And our clinic provides services to men, women, and children, victims of labor trafficking and sex trafficking. And our clients are both adults and children. And so it really runs the gamut. We see all types of human trafficking cases, and we provide as many types of legal services to those clients as we can. So we do immigration work, all sorts of family work, from child welfare to just you name it, public benefits. Post-adjudication criminal relief is a lot of words simply to say that lots of our clients, when they come to us, this is not the first time that they've encountered the criminal legal system. They often have a pretty hefty arrest record, and for when they were victims of human trafficking. And so we try to go back in and help them erase that arrest record so that they can move on and get jobs, do other things. We do tax work, some of my least favorite cases, identity protection, criminal justice advocacy. So those are the types of cases we do. You can think of us as a kind of like poverty law practice for survivors of human trafficking. So it's important that, and we use this term a lot, human trafficking. So I think it's important that we all know what I'm talking about. And I'm going to have the legal phrasing in a minute, but I want to give a layperson's definition first. Human trafficking is simply compelled service. It's when someone is compelled because of a vulnerability into doing some type of service, and that service can be in the commercial sex industry or really in any other type of industry. It can be a local restaurant. It can be, you know, the people who are picking our strawberries. It can even be, and we've actually seen these cases at universities where PhD advisors are using the power they have over foreign national PhD students to compel them to work. That was actually a case that we worked on out of Michigan State. And we know that can happen in lots of places. So it's anytime someone with a vulnerability is compelled into service for a profit. And that profit can be cash, or it can be something of value. So if I have someone in my home who I force to clean my home and I don't pay them, I'm not making money, but I'm not having to pay out money to have it done, or not having to do it myself. So that time that I'm saving has commercial value. So here are the legal standards for federal human trafficking law. And so I just wanted to put it up here because I get lots of questions about it. The big key thing is that in the US, we think about human trafficking as having two types: sex trafficking and labor trafficking. But they're very similar. Again, you can think about it as compelled service. I have another slide that will help us think about it. So when we think about labor trafficking, there's just a bunch of verbs, right? People can be recruited, they can be harbored, they can be transported, or they can be obtained or provided. So, right, you need a verb. And that can happen in a foreign country, or it can happen in the US. And then we have to have something that compels you, right? When we're talking about compelled service. So it's for labor trafficking, for adults and children, it's either through force or fraud or coercion that you are compelled. The most powerful word in that phrase is or, because it doesn't have to be force and fraud and coercion. It just needs to be one of the three. Psychological coercion is enough. Like in the case I was talking about, or in many of my cases, really, psychological coercion is the tool that traffickers use against their victims because it doesn't leave any physical marks. And the criminal legal system kind of loves evidence of physical marks because it's an easy thing to show to a jury or a decision maker, and traffickers know that. And so the lack of physical marks and psychological coercion makes it often the trafficker's tool of choice. And then the purpose has to be, this is very legalistic, involuntary servitude, debt, bondage, or slavery just kind of means in a job. That's not in the commercial sex industry, because the commercial sex industry is covered by the sex trafficking definition. So here we are in sex trafficking. And again, we have verbs, we've got to get somebody, but there's more verbs than for labor trafficking. Here we've added patronizing or soliciting. This was added to make it clear that someone purchasing a victim of human trafficking, especially a minor victim of sex trafficking, can be the trafficker, which is a side note, but I can explain that if folks want to know. For adults only, we need, again, force or fraud or coercion, and this time for the purposes of a commercial sex act. And commercial does a lot of work here. It needs to be a sex act that's performed in exchange for something of value. It can be cash, a place to spend the night, a Subway sandwich. For children, for minors, federally, it's a big mess in each state. You don't need to show force or fraud or coercion. It is their age that makes them a victim. Now, I want to just put a little asterisk on this for folks. Each state regulates prostitution in its own way. And so while on the federal level, meaning no FBI agent is going to arrest a 17-year-old who is being sold for sex, local and state police may in Michigan. And that's a side note, but I just want to flag that because there's lots of statutory reasons why that can occur. So this is a federal structure. Lots of folks want to know, who are we serving in the human trafficking clinic? And they want to say, what country do most of your clients come from? And the answer is they come from all over. We put this list together, I think maybe 2 years ago now. So it probably could be updated, but this is a great snapshot of sort of where our clients are coming from. And you see the United States, as mentioned there. This is not like a heat map or a prevalence map. We just put 1 star. We may have 20 victims from one country or just one. The other thing to know is that while almost all of my legal work is done in the United States, we also work with a number of partners in other countries to help them in their anti-trafficking work, most notably in Mexico, Brazil, and we're starting a project in Costa Rica very soon. If not for COVID, it probably would have been sooner. Then folks often want to know, here in Michigan, does it happen in my town? Do I have cases here? Again, this was probably updated 3 years ago as well. This is really just a sampling of places we have worked on cases in Michigan, and there have been human trafficking cases in every other state in the US. We haven't necessarily worked on all of those cases. So the answer is, wherever your here is, yes, human trafficking is happening in your community. Lots of folks want to know, like, where is it like happening the most? You know, is my community a hotspot? And the answer is, we don't know. We don't have a baseline prevalence estimate. We don't know which communities that it happens more in. We also don't know that certain events make it happen more, like the Super Bowl. That's a myth. So the one thing that is kept track of are calls to a national human trafficking hotline. Doesn't really tell us much. This is about reported tips. It really just tells us that the more we know about the issue, the more calls are made and the more cases we find. We're just still learning a ton about that. So empowerment, this is a fascinating concept for me to think about as a lawyer, because when you practice law, your client is the boss of you. And that's how we train our law students. It's how we talk about being lawyers with our clients. And so I sure hope that I am practicing empowerment in that way. My job is to make sure that my clients, that I understand what my clients' goals are, that I tell them what their choices are, and that I tell them how I think their choices, which choice they make, will either head them towards their goal or away from their goals. That's my entire job. Like, that's my ethical obligation. What also means is, though, that it's really important that I understand what my client's definition of success is, and that we make it clear to the people we're working with what my client's definition of success is. And the reason I say that is that in anti-human trafficking work, there's often a pretty narrow definition of what it means to do a successful case. And that definition is usually that a trafficker is put in jail. Now, do I like it when people who harm my clients are punished appropriately? Yes. However, that's not always the goal of my client. My client may not want someone that they deeply care about put in jail. My client may not want to participate in a highly traumatic criminal proceeding. And so I may be advocating, because it's my client's wishes, for no prosecution to happen, or just for my client to get her identity back, his or her identity back. And they don't at all want to ever talk to a prosecutor. Now, prosecutors and law enforcement, sometimes have really powerful tools, such as threatening jail time, or actually putting my client in jail to make my client change their mind, or force my client to do things that he or she doesn't want to. But it's really important that I am just following the strategy that my client wants me to follow, which means I have to spend, the law students have to spend a lot of time translating. I think of myself, lawyer as translator and lawyer as storyteller, to the client, what the legal system may or may not do, and then helping my client figure out what works for them. So the other thing more broadly on my work is that I think if you had asked me a couple of years ago whether I think about my work from an empowerment framework holistically, I likely would have said not as much. I think I'm really moving from kind of a human rights only framing of my work, right? Where you think about trafficking as depriving someone of their freedom and liberty. And I'm thinking about it in a much more pragmatic way these days. I'm thinking about human trafficking a lot as a relationship with work. And I don't mean that to minimize the horrors of trafficking. But what I mean is that my clients are harmed working, whether that's in the commercial sex industry, in a restaurant, in a research lab, in a hotel cleaning. And when my clients come out of that experience, they still have to work. They may not take the same type of job, or they may take the same type of job. And when you think about work and the relationship with work at the core of human trafficking, you begin to think about how can we empower, or I begin to think about how can we empower people to find workplace settings that help them flourish and thrive? How can we compete with traffickers in a recruitment model that makes legitimate work, flourishing work, as enticing at times as the work that traffickers are offering? The narrative around trafficking, that people are kidnapped or snatched and forced to be enslaved, is sometimes true. But in general, traffickers are offering a relationship, a connection, the ability to be seen and heard, often things that many workplace settings are not offering to my clients and are really just not offering to anyone, right? We know that there is a huge lack of engagement in workplace settings, that people don't feel seen and heard. And so I feel like the next phase of my work is to think about how we can create those settings. And when I think about measuring, I share some of Jody's questions about what does it mean to measure empowerment. But I've been doing a lot of work recently about how can we measure flourishing? How can we say whether this environment that someone's in is helping them thrive? And my hope is that people who are flourishing are people who are empowered. So thanks.
Thank you so much. That was excellent. So before we move to Q&A, I am going to experiment with some technology. This is where I know you all are probably making dinner. You're probably listening with, one AirPod bud in. I'm going to see if I can do two things. First, okay. I don't know if you can all see the chat or whether the chat is disabled. So there's that. The next thing I wanted to do is, in the event you happen to have your phone handy, can you see my little QR code? Did that come up on the screen? Okay, this should take you to a little survey that's going to ask you some questions. And the first question is, of all the things we've talked about around empowerment, what are the words that come into your brain about what we're talking about? I've heard a lot of words already. I've heard empowerment and agency and self-efficacy. Love to hear what you all think, because if I can make this work, so I'm going to take down my little QR code thing. So going on. I'm going to share now the, hold that thought. So it'll take a minute to populate, but what do you think when we talk about all that we've been talking about? What are the words that come to mind? We've got personal agency and justice, rights and dignity, interdisciplinary, community, innovative, understanding, social justice. Exactly. And so this word cloud will continue to populate as you all enter your ideas. And we'll take a little screenshot at some point showing some of the things that we're thinking about in this space. And I find this so interesting because I think Jody's question for me of, is empowerment a process or is it an outcome, is so spot on. And I think there's so much room here for exploration. And, as one of the things I'm not sure that was clear in the beginning, this topic came up after Joe and John Ianian went around to all the deans and all these various high-level people at the university and talked about what are some of the things do you think your faculty could get behind? And there were several themes that emerged, and empowering women was one of them. So that's how this came about. So now we're talking about, okay, so what does that mean for the University of Michigan? That's where we are and trying to move this forward. So thinking about what do we mean by empowerment, there's agency, there's self-efficacy, there's, autonomy. There are all these constructs, each of which has its own definition and its own use. So this, we were hoping we would give you an opportunity to see just how wide-ranging we're thinking about this. So the next slide asks you, I think you can advance. Your next slide asks you, I hope I can do this. Let me then stop share real quick and hold that thought. The next slide, which I think you ought to be able to answer using the same thing, is what does empowering communities mean to you? And I don't know if, are you able to see this?
See, we can't see the slide, but we can see it on the Mentimeter.
You can see it on the Mentimeter thing, okay. Well, I can't quite figure out what's happening with my Mentimeter slide, but enter in your things of what community means to you, because that's the other question, is what does community mean? And how can we think about what does empowering communities mean? Let's see if I can get this to work. Is it working? Oh, there we go. Beautiful. Two-way street, economic independence, empowering girls, respect, consensus, diversity, representation. This too is another illustration of the many different ways we could think about empowering communities. So for each of the panelists, and I'm sure each of you watching, you could probably think about how empowering women has a different idea than someone else, and the same with empowering communities. And I would also hazard to guess that many of us don't necessarily define our work based on, I want to go empower women in communities. We define it around whatever area it is that we're working in, whether that's maternal and newborn health, whether that's HIV, whether that's communication, et cetera. So it creates an interesting opportunity when, as a university, we want to get as many different people around the table as possible to say, hey, what would make us all come together? And how might we think about engaging around this topic? And how would we know if we've done it? Because I think that's the other question. When we talk about impact, how would we know if we've had an impact in this space? And I think this harkens back to Tachi Yamada saying, you know, often women are seen as the victim when in many cases they are the heart of their communities, they're the heart of their families, and are often the ones who can make a huge difference. They talk about microfinance loans. If you give them to women, they invest them in their families. Those same loans given to men in rural communities don't always turn out quite that way. So anyway, this is a very long introduction of saying, we've got a lot of diversity in this team and then this space, and I hope someone is taking a screenshot, because I'm going to stop sharing now, and I'm going to ask the panelists to turn their videos back on. And I think we can start working through some of these questions. So let's see. First question is for Jody. And Jody, the question says, in many low-income countries, women are, quote unquote, in the hands of others. Husbands consent for life-saving interventions during delivery, mother-in-laws, perceptions about antenatal care, et cetera. What are your thoughts around engaging men in sexual and reproductive health as a way to reach a positive transformation and change?
That's a really good question. Thank you for that question. I do think that male involvement is an important strategy when we think about preventing maternal mortality and morbidity. I think it's especially important in areas where we're talking about accessing antenatal care or coming in for facility delivery, where sometimes men, not only men, but other family members underestimate the importance of those services that women access in the healthcare system. So I think not only men, but all other parts of the family need to be brought into this. And I think there's also some misperceptions, I think, on even the part of women, because I can totally recall one time when I was with a group of women in very rural Liberia. We were inside a building and we were having a community meeting with the women in the community. And we were talking about danger signs of pregnancy. And I looked at the window and all at the outside windows where all the men were like looking in like this, and they wanted to see what's going on inside. And they said, why aren't you including us? But the women said, oh, we can't include the men. Men don't know, men don't talk about this. We don't share this with the men. Yet the men were there and they wanted to know what was going on. And they were like, why don't you invite us in? So I do think we miss opportunities sometimes to include men in sexual and reproductive health when we talk about women's health and about pregnancy health.
I'm just going to follow up before moving on to some of the other questions. One of the things I've struggled with is we use this word empowerment as if it's sort of giving power to one group, which may imply taking power from another. And then we'll get to it in a bit. There's a great question that Gary asks about this idea of hierarchy and being careful about this idea that empowering is sort of swooping in and saying, we're giving you power. So one of my questions for all the panelists actually is thinking about empowerment, and is it a individual thing that we can give to women without determining how that affects balances in the community? And is it more interrelated, that there's community and there's men and there's all kinds of other things? So Bridgette, can I ask you to start and tell us a little bit about what you think with regard to whether empowerment is sort of more of an individual thing for individual women, or whether it's more of a collective, and is it a zero-sum game? What are your thoughts? Oh, you're muted.
Sorry. I think that communities often limit access to empowerment because people worry it's a zero-sum game. And you see that all the time in legal structures or cultural norms. So I often think about it as, empowerment as access and full information conveyed in a way that can be received. And so, I don't know, I think such a lawyer answer, I think all of those things are interrelated.
Excellent. Elizabeth, do you have anything to add?
I guess not right now. Sorry, I turned on my microphone and then I was like, no. I think that there's a lot of questions and I'm not sure which one to start with. So let me think a little bit about it. But I think that, I agree with what's been said about it not being a zero-sum game. I think there's another question embedded there of times if we're thinking back on kind of what, if we're thinking, each presenter talked about it in a different way of what that means, right? Sometimes it is is it an issue of looking at when we use the theory of gender and power in our research, in doing Russia, and we think about it, but I think that there's another thing where we're stepping back as the Center for Global Health and Equity and thinking is that the idea of empowering communities? I do think, I agree with what Gary's getting at, is that we should pause to think more about what that means, given there's so many other issues, but we only have 20 minutes, but maybe that's part of the virtual jam that's coming up.
Right. So let me just, let me read Gary's question, and then I want to bump down to Ruth's comment after that. And I know I'm taking the questions out of order. I hope we can get to all of them. So Gary says one thing we have to be careful about when using terms like empowerment and empowering others in the global context is that it assumes a hierarchical relationship where we're coming into communities with the knowledge and power and we are helping them. Women in communities have a good deal of power, strength, and resilience, and I think we need to make sure we're not imposing our values and conceptualizations of health and well-being on them. Many countries have a long history of colonization, and we need to be careful not to engage in inadvertent or blatant forms of colonization, which I think all of us would absolutely agree with. And I think Jody's example of listening to the community and Bridgette's example of listening to her clients and trying to respond, I think is a great example of not assuming anything from the outset. But that raises Ruth's question, should we be using a different word? Maybe empowerment is too intimidating for those in power. And, sometimes people say, oh, it's just words, but I do think words matter. So thoughts from any of you on whether we should be using a different word? Jody, go ahead.
I think that's why I struggle with the word. I think it's, I don't even really like the word that much. And so I've never really considered like the work that I do, like empowerment work. It's really interesting when somebody asks you a question like that. I was also asked to be on a panel one time because to talk about my my advocacy work. And I thought, why does that person think that I do advocacy work? So I think it's really, I mean, everybody has a little different take on all of these words and all of the way that we think about the words. But I do wonder too, maybe it should just be power. Maybe it shouldn't be empowerment.
I was really struck as I listened to all three talks about, instead of having this theme of empowerment, there was this theme of communication and listening and people being heard and seeing their own ideas implemented in their communities. And Bridgette, did you use the word fulfillment or use some word like that? Like instead of being empowering, that it was a lot helping people implement their own ideas and thoughts and how their community could be improved. I was really struck by that. Was just a common theme throughout all of the discussion.
Almost like validating.
Validating, I think it's a great word.
Yeah. Which raises another question. I would love to know if, when we talk about empowering or validating or giving women agency, love to hear what the panelists think about when that may mean. And Bridgette, I'm sure you have probably witnessed this more than the rest of us, when empowering women to make their own decisions leads them to do something that we would see as not ideal. Like, for example, going to a traditional healer when we would rather they go to the healthcare center with a Western trained provider. While that's empowering because they are able to make their own choices, and yet those wouldn't necessarily be the public health oriented choices that we might want. And yet that's part and parcel. Bridgette, I'd love for your comments on that.
Yes, this is, so, we have cases where we help labor trafficking victims who've been forced to do landscape work. And once they're out of that experience, they may open up their own landscaping company, or they may join another landscaping company, and people generally are happy that they're doing that. And they're like, so glad they're going to use these skills and, that they have. We have clients who were forced to work in strip clubs. And when they choose, after they're out of that situation, some of them, to return to that work, people do not have the same response. And sometimes even people sort of, in the anti-trafficking world. And so we do, I do a lot of work just trying to remind folks that it feels like it all comes back to the core of my parenting, which is teaching my kids that they are the boss of their body. And as long as someone, as long as someone is the boss of their own body and is getting the information they need and knows what their choices are and they get to choose, that's the victory. That's what we should be celebrating. And so, especially in my work, I will often reframe something that's happening into a labor trafficking context for folks. And then they see it rather than a sex trafficking context where they get caught up in what they think people's choices should be. I also just want to say one thing. I'm always interested when I'm in these conversations around campus about community engagement or anything. It's very interesting to come to them as a lawyer because, I'll often hear people talk about we can't just take from communities, and this framing that we have, which is they hire us and they fire us. We are so we've been fired many times. And that's fine if we're not doing the right thing. And so it's a sometimes just super interesting narrative because I feel like I sometimes say, I don't know, I can't be less in control than often how we are. So yeah.
I would love to know what would happen if communities could fire researchers. Can you imagine? You're fired. That would change the dynamic tremendously. So here's a question from Carlos for Dr. King. In many different settings here in the US and across the world, social structural factors or social determinants such as housing instability and employment and financial insecurity affect not just access to care, but also adherence to healthcare interventions. Can you speak a bit more about the presence of such social determinants in the women's HIV positive population in Russia and how they affect non-adherence and discontinuation of HIV care?
Okay, Carlos, if you have an hour. Just kidding. But I know it's a great question. So yes, I could talk about it. But I wanted to also say, like, the idea of, can I just really quickly kind of continue with that idea of like communities firing researchers? I actually think that the communities that have power and have agency actually can choose which researchers to work with. And so, I mean, I think that I realize that you were playing on words, but I think we should stop to think about that. And then we would think about, you know, what kind of partnerships that we would engage in, and like, so that they could, right? So it would be part of that for further discussion as well. So yeah, and I saw that Rick also had a question, and that was so I'll just tie them together since his and Carlos can be there. I'll shortly answer them, but if you want to talk about either of them more, we can obviously do that another time. But so the reason we chose the 2-month window is that so children who are born to HIV positive mothers in Russia will stay on the registry for 2 years, and women go with them to receive care, but being siloed, they go for pediatric care. And so it's separate. So yes, they do stay, but that's what we're trying to understand is how do they stay engaged for their own needs, not just for their children's needs. And that, yeah, so the social determinants, I mean, I think I briefly mentioned some of them, right? Like when I went over them, but the biggest ones are, I mean, yes, housing insecurity, financial insecurity are really big, employment to some extent, but financial insecurity and food insecurity are ones that we continue to see. And then, yeah, so those are ones that would definitely need to be taken into account. Yeah, but I'll just send you the paper and then we can talk about it, Carlos. But yes, all great questions and lots to talk about there. Yeah, it's more than.
I appreciate Gary's question, the next one. Can you clarify if this group is focused on both women and communities, or if it's really about women in the context of their communities? Both topics, women and communities, deserve their own space for exploration in the global context. This is precisely the types of things we hope to hammer out at the Research Jam. So again, for those of you joining late, there's a Research Jam coming up December 9th from 2 to 5. We have a few spaces left. It's obviously it's 3-hour commitment, so that's a long time. But if you can come and are interested in helping us shape this, we would love to have you. You can send an email to any one of us and we can sort that out. Great question. Don't know the answer yet. Check back. And I agree. I think these are huge topics. I think talking about empowering women, empowering communities is almost as huge as saying global health or health. It's just huge. So the real question is, how do we start to hone it down into something that still maintains a big umbrella? Because I've learned so much tonight from the different perspectives. So keeping this umbrella big, because that's how we're going to move the dial and how we're going to learn. At the same time, keeping it manageable so that there is a cohesive identity and people can find themselves here. So I think that would be my response to that question. So Julia, thanks for coming, asked a question, and Julia's published a paper recently on empowerment and immunizations, just so you know. What are the panelists' thoughts and or experiences regarding measuring and or creating interventions to promote empowerment in rural versus urban places? Ooh, that's a tough question. Who wants to take that? Dead silence. Elizabeth, you look like you have something to say.
Wow, I have to get rid of that look. No, I think it's a really important question. I kind of thinking Jody was going to take it, but I do think, I mean, part of the purpose of the study, which I didn't go into each of what all these regions in Russia mean, is that we are trying to look at like more, there's urban, and look at some of the nuances between even the barriers or facilitators that influence women's engagement in care. So they might be the same, right? Stigma is pretty pervasive, but it's different in rural Siberia as compared to Moscow, right? Or even like the small towns around Moscow. So we try to have had variety in that with the regional disparities that I talked about. And I think that it's definitely important consideration in other settings that I work as well. But yeah, so I was looking like I had something to say because it was a good question I was pondering.
Cheryl, can I add a little to that? So this is a different framing, but one of the things I often think about is that how we frame our own work often drives us to certain answers. So if you do human rights lawyering, right, the mechanisms you use are often in very urban settings, right? You need access to certain courts, you need certain types of resources. If you think your work is instead about how to create workplace opportunities or how to recruit workers in the same way traffickers do, and traffickers are really good at targeting folks in rural areas as well as urban, it begins to reframe kind of the field you're playing on. And so I think that's one of the things that I keep coming back to is we, at least in my field, we've built up all these mechanisms and structures that to get your rights honored happen in mostly urban spaces. But if we frame our work differently, so it's often, I think sometimes the question we ask for me, not necessarily how we measure it, that leads us in these different places.
And I'll just add, I think it's a great question. And I do think that you have to think differently about measuring and creating interventions for rural and urban places because populations are often starting at very, very different levels, right? So in urban areas, my experience has been that women, and I'm going to use women because that's the group that I'm most familiar with in my research. In urban areas, they often have more education, they have more access to resources, they have, they just have a lot more opportunities than they do in the rural areas. So you're starting out at a very different place. So I do think that you're having to measure things in a very different way.
Well, and I think that brings up Jody. There's another question for you from Roy Clark that says, as an engineer, I think of empowering very literally, providing electrical power to off-grid maternity clinics in East Africa. So what are some of the ways this can have an impact in this context? And I think about that in terms of urban, rural, and the availability of different structural mechanisms for this.
Absolutely, because then you're not only, then you're actually also empowering the care provider, right? Because the care provider's been working in the dark, and you can imagine delivering babies in the dark or trying to take care of any kind of problem that would come in the middle of the night with no electricity. How do you start an IV when you have maybe a headlamp that you're using? And if Roy's worked in these areas, he knows, it really, it limits the amount of care that you can provide, quality care for sure that you can provide if you don't have any kind of lighting or electricity. So I totally agree. I think that's a very empowering thing. No pun intended.
Well, and then building on that, Emily Wendell came, thank you, and asked an interesting question. A lot of the issues that have been brought up and are being researched are systemic issues that stem from gender roles and power dynamics. How do you all approach these different research topics without getting overwhelmed by the systemic breadth of them all? And let's see, who should we start with?
Well, if I somehow conveyed that I am not overwhelmed by systemic patriarchy and misogyny and gender discrimination, I have not conveyed myself well tonight, because I am utterly overwhelmed by them all the time. And nevertheless, we persist. That's just what we do.
And I totally agree with that.
Elizabeth?
Yeah, sorry, I was too overwhelmed to unmute. Yes.
And Cheryl, I mean, you work in these contexts too. I mean, it is really easy to get overwhelmed, like whatever you work with a stateless population or rural population without access. How do you, I mean, you get overwhelmed. It's kind of like COVID, I think, every day you figure you make it to the next day or the next research project, I guess.
Well, and I think some of it for me has always been, you can do that little fish diagram that shows the root of the problem. And the root of the problem is so far from what I can influence. So there's that question of, ideally women need education, girls need education, and need to be treated as though their education matters. But then once they're educated, there need to be equal opportunities for employment, et cetera. And healthcare settings, healthcare providers need to be well-trained, but they also need equipment and supplies that's reliable. And, oh, wait, you need roads to be able to get to those facilities. And without roads, et cetera, et cetera. But I am not a road builder. I am not a, supply chain manager. So I always think about sort of what piece can I try to have an impact on. But absolutely, there are plenty of times where I throw my hands up and think, oh my gosh, this is, just a spit in the ocean. And yet, as Bridgette said, we persist and try to make the small differences that we can. And one of the things I was really struck by that Elizabeth said that I thought was so interesting was that you had community members distributing information about your findings through social media and blogs, et cetera. You had communities so engaged in this work that they felt the need to tell everybody about it. That to me is an example of making a huge difference on so many levels, not only the information that went out, but the fact that you were able to mobilize community members and your research staff to be so excited about this work that they wanted to tell everybody about it and put it on social media. So kudos, absolute kudos, because I think that's a great example of empowering.
Yeah, and Cheryl, can I add one thing?
Partnerships that do it. Like luckily with these partnerships, there's not I'm not really a mobilizer. So it also helps in that, we find like that element from partnerships from the beginning really helps and for thinking about that. Yeah. But so I'm excited about it, but I didn't want to make it sound like I could take credit for that aspect.
So one tangible thing we do about that though, is we celebrate everything. And I think it's a really important thing. It's something we train our students about all the time. It's something, we celebrate the small successes. We celebrate that a client's still alive. We celebrate that a client we haven't heard from in a year and a half calls us back. And so I think it can be really overwhelming in these spaces, just, that we breathe in all this, stuff, discrimination. And so how can we be sure to celebrate every single victory? And our brains are so wired to, even after we achieve something, to move right to the next thing. So I got that paper published. So now I've got to do that new grant application, trying to speak y'all's language because I don't do that. But so it's like, no, sit in the success of the publication. And so that is a tool I use actually all the time to keep persisting.
Well, and from that, I think getting back to Rick Neitzel's question, so these women, these communities that you work in, do you see, you must see long-term impacts, like, as children grow, as women and, victims, as, do you visually see like it impact a better life? Can you maybe talk a little bit about that?
Yeah, I feel so lucky compared to law enforcement or the prosecutor's office or, others who their sole focus is that experience of victimization. They have that one slice of my client's life where I'm getting, invited to the weddings and the college graduations and the touch base just to let you know that I got a new job. And so, my experience with my clients is that trafficking is just one experience in their life. And so I get to see the fullness of their experience and the fullness that's possible because they were able to step out of that. And that's really healthy for my brain and for me as an advocate, and to see that impact.
And I think when women come in, and I think one of the things that some of these interventions have done is that it gives them a connection with the health system. And when they're treated respectfully, when they go in, if they feel like they're in a partnership, then they're more likely to go back when their child has a respiratory illness, or they feel like they have a question about family planning or some other aspect in their life, that if they've been treated with respect and they've been treated with care at the health facility, then it just makes it so much easier for them to continue to access care later on after they have the baby and after their pregnancy is over.
Yeah, I mean, I just think about like when we're focusing specifically on research projects and doing research, like having all of these, I mean, when we have several people across a lot of time zones, especially when I'm in Ann Arbor, right, then it's even more time zones, but like having, we definitely have like communication, like Bridgette's saying, like celebrating every little step. And some of that is, I mean, the thing of like doing a survey, right? Like we had someone who's like, well, they didn't, we're like, oh, I've only done 2 surveys. Thinking, well, that's not very many surveys, like in like a pretty big window, we're not going to make our target. But then it's because like, they're like, oh, well, because this person answered that they hadn't been engaged in care. And so I spent, the next 3 days helping them get linked up with this care. So even like through the process of research, making some of those connections, et cetera, and seeing that will helps add to those, but also having, we definitely have like, WhatsApp chat groups, et cetera, where I actually think probably community activists are better than maybe university researchers about celebrating and sharing achievements and having that a lot of the processing that goes along with in the research meetings as well. So, yeah.
Well, with that, we should probably go celebrate a really great webinar and go celebrate with our friends and family, and thank everybody for coming in a Thursday in the middle of November when it's already been a rough week. And just invite everybody that had questions, especially questions about what this is, to get in touch with us, come to the research jam, just engage in any way. And I'm sure Cheryl, you'll echo that as we say goodbye, right?
Absolutely. Absolutely. It is an open table where you're so looking forward to engaging at whatever level, and please reach out. CA Moyer, and you're L Rozek, right?
No, do not. L Rozek does not forward email. Rozek L is me. I don't blame her. I think she gets all of my email. I feel like I should send her a gift. Rozek L, and just get in touch with anybody. And thank you so much to our panelists. This was really enjoyable and informative. And I know I took a whole page of notes. So thank you so much for taking the time to do this.
Absolutely. I learned so much. Thank you all.